Although we do not have the time to quite fully delve into the intricacies of treatment, it's worth noting some general principles which highlight the importance of determining the correct etiology. For example, in our pre-renal states, we want to give back the fluid that they lost. For example, in those patients with hypovolemia, we want to stop medications that are preventing them from getting those fluid, like our diuretics. And in certain cases, like those cirrhotic patients, and we're worried about hepatorenal syndrome, we can think about medications specific to that condition that might raise the blood pressure, that might increase the flow to the kidneys, possibly through oncotic pressure or through hydrostatic pressure with things like vasopressors. Next, we think about our intrarenal injuries, and these are even more important to be specific to the type of injury because in a patient with sepsis, we're going to be treating that infection. If that's causing the ATN, we want to make sure we're controlling the INOs instead of just giving them a significant positive fluid balance. On the other hand, if a patient has AIN, we're going to remove the offending agent and maybe even give them steroids. Next, when we think about our post-renal etiologies, we want to think about if they have a urethral obstruction, getting that Foley in quickly, as we mentioned. And if they are having crystal disease, let's get them adequate hydration. On those rare cases of abdominal compartment syndrome, those patients often with ascites who might be having some compression of the kidney because of that, you'll usually expect to see a bladder pressure, I believe, of around 18 in these cases. We want to call our surgeons really quickly because that's going to be a surgical emergency for decompression. Next, we'll head to the MICU where we booked our patient who might need emergent hemodialysis, and you can see some of those indicators we mentioned earlier. And beginning with the first of these, we'll think of an acidemia. So while there's no set pH or bicarbonate measurement at which we start supplementation, it's known physiologically that below a pH of 7.1, patients can start having more difficulty with oxygen extraction and function at a cellular level. This can be repleted PO, but with something like baking soda. But honestly, we're giving that IV if this patient is in the medical intensive care unit. Next, we want to think about those electrolyte abnormalities specific to potassium, and we want to think about the difference. What's going to be an initial acute treatment, things that stabilize the cardiac membranes with calcium, or things that can help shunt the potassium into the cells, whether that's insulin or bicarbonate. And then we want to think about more long-term loss of the potassium with things like Kxalate, which is a resin that exchanges sodium for potassium, and it's excreted in the stool. Next, for intoxications, we want to be thinking about our patients and getting them a lot of fluids, honestly, for the most part, to flush it out. And if we know what it is, we got to get that urine toxicology or, an overdose panel. We can see if something like ethylene glycol is present. We can give them a competitive inhibitor like a fameprazole. If this patient has volume overload, we can look to see if they symptomatically might need a thoracentesis or a paracentesis to take some of that volume off. And then finally, if overall this constellation produces a significant uremia, like those rubs that I mentioned, then we want to start thinking about hemodialysis. So although hemodialysis will be described in more depth in the chronic kidney disease video lecture, it's worth briefly mentioning the types of hemodialysis acutely. So generally speaking, hemodialysis uses a gradient between the patient's blood and the diastole to remove chemicals and volume. In the emergent setting, a non-tunneled temporary hemodialysis catheter can be placed in the internal jugular vein or the femoral vein, which is less appropriate as it is more of a dirty site. So we place this in the IJ or the femoral vein, and this removes blood into a machine that filters it in the setting of diastole, which can help clear, based on osmosis, can help clear some of those chemicals that we had before, and the blood is then returned back to the body. This can be either intermittent hemodialysis, which can be very effective to clear chemicals, correct electrolytes, and remove volume, although it does place the patient at some risk for hemodynamic instability, specifically blood pressure. On the other hand, This patient can also have these avoided if they receive a more continuous version of hemodialysis called central veno-venous hemofiltration, which runs at a much slower rate but requires more regulation from the nursing staff. A balance of the two is something called SLED, or sustained low efficiency daily dialysis, which removes fluid more quickly than CVVH, but not at the same rate as intermittent hemodialysis. Finally, prevention of future acute kidney injuries is a combination of close follow-up with nephrology and the primary to trend the creatinine and to establish a new baseline. We want to make sure we have them eating an appropriate diet, but also make sure that they're taking the right medications, whether that's for their everyday medications, for things like their heart failure, or for their pain medications. We want to avoid NSAIDs, or at least significant quantities of NSAIDs at any given time. Then, if we note that the patient is starting to get to that CKD stage 4, which is going to be a GFR of less than 30, we want to start beginning this question of whether they would be open to hemodialysis in the future, because if there were to be an emergent situation, a lot of patients can be very resistant to this. To review, we are going to talk about how this all translates into our note. So after hurriedly typing up our history, physical, labs, and injury, we can now focus on the plan for what we're doing for this acute kidney injury. First, we want to mention our leading diagnosis and the differential, whether that's pre-renal, intrarenal, and post-renal. We can then list our respective interventions specific to the type of AKI. Are we giving them fluids? Are we deseeing the offending agent? Are we treating their sepsis? We also want to talk about what we're doing to monitor these patients. This includes trending their BUN to creatinine. How frequently do we need to see this? And what kind of medications should they be avoiding? And what are their blood pressure goals if we want to keep them from being too hypotensive? Next, we want to think about those electrolytes, once again harping on the potassium and those immediate versus long-lasting measures. Then we want to think about treating their acidemia. While we might have initially been given that IV in the intensive care unit, that can sometimes be switched over to PO, especially if it's a chronic kidney disease and it's going to take some time for them to catch up, or if they're going to need some baseline supplementation. And then finally, we want to talk about their volume status. So this goes for whether they're hypovolemic to hypervolemic, what type of fluids they're going to be getting in that state. We want to be measuring their strict I's and O's. This includes from their urine output, oftentimes with a Foley, but also through their daily weights. We think of that especially in our patients with CHF and cirrhosis. Finally, if they're getting renal replacement therapy or hemodialysis, we want to think about the type, the frequency, and any supplemental agents during hemodialysis, including midodrine. So that's it, guys. Let's review some take-home points. So first off, when it comes to this patient with acute kidney injury, let's eyeball them. Make sure they don't need acute dialysis, and this might include getting an EKG or an ABG at that time. We also want to say, is this even an acute kidney injury? Let's take a look back in the history and see what the trends are, because those are much more important than individual numbers. We want to start making a differential diagnosis, taking out our magnifying glass and looking at things like the medications they're taking, both prescribed and over the counter, and what was happening in their procedures in their hospital for possible iatrogenic injuries. Next, we want to sift through the data. This includes their fractional excreted sodium and their BUN to creatinine ratios, although, once again, those aren't always consistent. One thing that can be really helpful instead is the urine microscopy. It's cheap and it's really, really helpful. You saw those likelihood ratios. Next, we want to think about our treatment. Emergencies first, so that's whether they need hemodialysis, and then it's also some of those acute changes and acute treatments that we can make specific to each diagnosis. These include monitoring for those hemodialysis criteria and includes the type of hemodialysis. Finally, when we're writing this patient up, we want to think about our etiology, but we also want to think of 3 general categories, including our electrolytes, our acidemia, and our volume, that we're going to be correct. So that's it, guys. It was great working with you today. I hope you learned a little bit. And if you guys need a little bit of refreshing and you don't want to hear my voice again, there is a primer for acute kidney injury that you guys are most certainly welcome. It's something that I wrote with Dr. Luciano as well, in addition to this sample case. Dr. Luciano also wrote a wonderful primer on AKI and the critically ill. This was back when he was a resident here at Yale. Finally, if you want to go to the primary literature to see if I'm making some of those numbers up, for all of you physical exam diagnosticians, the wonderful Stephen McGee had a paper in JAMA, the Rational Clinical Examiner series, in 1999, which gave us those numbers on likelihood ratios for hypovolemia. Then a lot of the data on acute kidney injury came from this 2015 article of Kidney International. And also, finally, I'm very excited to also say some of those markers and numbers we talked about specific to the casts. These are better discussed by our very own Dr. Parizella in his article, Urine Sediment as a Biomarker of Kidney Disease, which was published this past year in the American Journal of Kidney Disease. So, thank you so much for your attention, and it really has been a pleasure.